Welcome today to this CVCT Cardiobrief interview with Steve Nissen and Milton Packer. Both of them are very famous cardiovascular clinical trialists. And the topic of discussion today is precisely clinical trials in heart failure with preserved ejection fraction, because recently we had trials which were perceived as being neutral. And this is the Paragon trial with sacubitril valsartan, and also with the MRA spironolactone, the TopCat trial. Both of them have been perceived as being neutral, and therefore, at the end of the day, we are left without any cure for HFpEF. And for this reason, and maybe for other reasons, there was from the sponsor, Paragon with Novartis, but also from the investigators, TopCat, a request to the FDA to re-examine the trials because they felt that there are ways to reinterpret the results in a way that they may allow for have future medication for HFpEF, whether it is sacubitril valsartan or TopCat. So I'd like first to ask Milton to set the stage and explain what were the issues about Paragon, and I will try to summarize the issues about TopCat, and then we'll discuss how these votes worked out and whether this may or may not progress to approval of one or two medication in HFpEF. Milton.
So, Fayaz, I'm really delighted to be with here with you and Steve. Let me just briefly summarize Paragon. Paragon was a trial of heart failure with preserved ejection fraction of 45% or greater. The trial randomized about 4,800 patients to either sacubitril valsartan or valsartan. So it was a test of the efficacy of sacubitril, which is a neprilysin inhibitor. The trial primary result was a effect on cardiovascular death and repeated hospitalizations for heart failure, a composite of repeated events. And the trial reported a 13% reduction in the risk of the primary endpoint with a p-value of 0.059. There were two subgroups of interest for the primary endpoint. There was a significant interaction by sex, with women having a greater effect than men. And there was a significant interaction by ejection fraction, with patients having with a lower ejection fraction having a greater effect than patients with higher ejection fractions. There were secondary analyses, secondary endpoints that were tested that favored the efficacy of sacubitril valsartan over valsartan. And there were post hoc analyses that supported the effect on the primary endpoint. So overall, an effect on the primary endpoint that was borderline with an effect size that was modest at 13% reduction in risk.
So let me just say, I think, Milton, you did a good job of explaining what we saw. And, Paragon was done carefully. And whenever we see a borderline result in an FDA advisory panel, it's difficult. There isn't a huge difference between a p-value of 0.059 and a p-value of 0.049. What we also saw is that the events in Paragon were adjudicated. And that resulted in a fairly significant number of events that the adjudicators were unable to confirm that they met the criteria for being an event. And one of the more interesting things about the discussion is that when you looked at investigator-reported events, there was actually a statistically significant or nominally significant result. In the group that had truly preserved ejection fraction, there did not appear to be a benefit. That's the group that was in the above the median ejection fraction. But within that group that had lower ranges of ejection fraction, the evidence was actually pretty good that there was a benefit. Now, what a normal ejection fraction is difficult to actually ascertain, but most people think that, if you're above 50%, you're probably normal. And what we ended up saying, most of us on the panel, was that we thought between paradigm and paradigm, there was reasonable evidence for these people. You can call it two things: mildly reduced ejection fraction or mid-range ejection fraction. Either way you define it, it looks like sacubitril/valsartan provides a benefit. And so we didn't say to the FDA, we want you to give a label for sacubitril/valsartan for preserved ejection fraction. We said we want you to give a label and I said, I was in the affirmative here. We think you ought to give a label for these below normal, but not truly very low ejection fractions.
It was interesting that the sponsor requested an indication only for the group with the lower ejection fraction range. With the other piece of information, which all of us have been really fascinated by, is the fact that since 2003, we've been defining heart failure with a reduced ejection fraction as less as 40% or less, but in truth, that's arbitrary. And for other trials with angiotensin receptor blockers, trials with beta blockers, trials with mineralocorticoid receptor antagonists, there has been this same pattern where you have a positive trial in heart failure with a reduced ejection fraction, and you have this, it's a subgroup of people who, quote, have preserved ejection fraction, but who really have mildly reduced ejection fractions, and they respond across multiple classes, like people with heart failure and a reduced ejection fraction. So I think the feeling that we're getting is that sacubitril/valsartan really is not a drug for HFpEF. It's a drug for heart failure and a reduced ejection fraction, but you have to have the threshold for ejection fraction to be higher than 40%. Does that make sense?
Yeah, we had an interesting interaction, Scott Solomon and I, who was presenting on behalf of the sponsor.
Yeah.
And I said, Scott, what do you consider one standard deviation for measurement of ejection fraction in the very best echo labs in the world?
Yeah.
And and I poked at him a little bit, because it's probably about 7 or 8% just for one standard deviation. And so if somebody says, well, the ejection fraction is 40, it's not, it's somewhere in that range, but some of those people, and in Paradigm, what we saw was there were people who, probably were in that 40 to 50% range. They just weren't, it wasn't the way the trial was defined. And so part of the problem is the metric that we're using, which is the echo ejection fraction, is not a very precise technique. And so what we have to say is, if you have signs and symptoms that are consistent with HFrEF and a lower range ejection fraction, we ought to consider treating you, because there's probably an outcome advantage.
Yeah, and Steve, I just to underscore one other point that you made, I have been a strong advocate of the fact that we should not be worshiping at the altar of a p-value of 0.05. It's arbitrary. And if we do that, what we do is we take a p-value of 0.051 and we philosophically equate that with a p-value of 0.099. And that's not right. Those are not equivalent p-values. Yeah.
By the way, one other little interaction I had with Scott Solomon is he said, for most of his career, people referred to echo ejection fraction as mild, moderate, or severe, and never gave a number.
Yeah.
And then the oncologists came along, and when they started to talk about cardio-oncology, they said, you got to give us a number, because we're given these drugs that are toxic to the heart, and we want to know. And so it became this idea that if your ejection fraction, when you got a chemotherapeutic agent, dropped from 54 to 49, oh my God, maybe we better stop the drug.
Yeah.
And so the whole idea of putting a number around it, frankly, is ludicrous. We ought to be reading echoes as showing normal, mild, moderate, and severe. Put it in those buckets. And if you do that, then both mild, moderate, and severe reductions appear to respond to sacubitril/valsartan.
So
Well,
the thing that's really sort of even more funny about this is that you've been talking about the measurement ejection fraction under what might be called optimal condition. And the world doesn't typically operate under optimal conditions. And it's particularly true when you have a disease like so-called HFpEF, where there's a meaningful prevalence of atrial fibrillation. And if you have atrial fibrillation on an echocardiogram and you try to measure ejection fraction, you have incredible latitude as to what beats you actually decide to analyze. So your 7% for atrial fibrillation becomes 15% or whatever the number might be. We are no longer in a realm of having a reliable number. We are in the realm of having an impression.
Well, there's one more issue, which is a fair number of these patients are obese.
Yes.
And they don't make very good pictures by echocardiography.
No.
But the word preserved was, I was asked to draft a label. You know, I actually, at the panel meeting, I actually drafted a label. And in that label, I didn't have the word preserved.
Right.
So what was the cutoff of EF that you've drafted in the label? Because at some point you need to define this in the label, right?
We talked about 50% as being the lower limit of normal. But, you know, keep in mind what Milton just said. You know, if you're in atrial fibrillation, 50 can be 45 or it can be 55. I'm going to tell you what I think is that they ought to give this label, but good clinicians ought to look at patients who are symptomatic, look at the echo. If it's really not quite normal, if it somehow falls into that category, then you might think about giving the patient the therapy. And if they feel better, then you did the right thing.
I know that many people say, we don't need adjudication committees, and others say, well, adjudication committees are very important. And then we are re-examining the evidence in one single trial with 3 different set of events. So what is your position, whether we should keep moving with the critical event committees and official adjudication, whether you are confident enough that the investigator do a good job?
So Fayez, let me just strongly agree with what Steve just said. I just want to emphasize this. When, you know, whether the analysis of Paragon is done based on the predefined adjudication rules, whether it's done by the investigator reported event, whether it's done by the re-adjudication process, none of those results are different from each other. They all produce a borderline p-value. And what's really important is that the effect size, about a 13% reduction in risk, is the same for all of those. All of those basically produce the same result. The only reason that the p-value falls very slightly when you do investigator reported events or re-adjudicated events is because you're adding events. You're not adding an additional treatment effect. So that's it. So the reason why we adjudicate events it's such an interesting historical quirk. By the way, we can do a whole podcast just on the pros and cons of adjudication. Oh my God, what a complicated subject. But the truth is that the Paragon investigators used initially a very strict set of criteria. many trials don't use those criteria because they know that if they use those criteria, they're going to throw out events that are events, but for which not every tick box can be checked. The truth is that the treatment effect on the events that are excluded is exactly the same as the treatment effect of the events that are included. So when you add them, the effect size doesn't change, but the p-value falls because you have more events. So, I mean, essentially, we're doing the same thing. We're getting the same result. And, just like we shouldn't worship at p-values, we shouldn't worship at adjudication. The truth is that if every way that you look at the data, adjudicated, not adjudicated, re-adjudicated, if the results are the same, then that's the result.
Thank you so much for this discussion, but let me frame it and let's put aside the adjudication and the p-value aside and summarize that the bottom line in your understanding of this trial is that HFpEF may or may not be redefined, but it appears that there is a subgroup of patients with not totally normal ejection fraction. Because of the continuity of the benefit from paradigm, you can actually be flexible enough to accept that this subgroup of patients, up to 50% of ejection fraction, may be benefiting from this medication, right?
Yes.
Good.
But I didn't use a number. I said mildly reduced, and that was, I didn't put a number in it. When I was asked to kind of write a draft label, I didn't put a number in there.
Okay, so we'll see how it will end up at the label of the FDA, if any. So let's get to TopCap now. It's another story. It became at the same time at the FDA with more or less the same advisory committee. And this is a trial with spironolactone in, again, HFpEF. The issues were slightly different here. The issue is that the trial was conducted in some Eastern countries, Georgia and Russia, and also in the Americas, Canada, United States, and South America. And then the trial was also overall judged as being neutral. But then when the investigator looked into the subgroup, they found actually that Russia and Georgia patients had hardly the disease. They had an event rate that was extremely low. And in addition, there were subsequent publications showing that the adherence to medication was very low in Georgia and Russia, and their creatinine or potassium hardly changed in these countries. And therefore, there was a temptation to look only into the result in the Americas. And guess what? When we look into this subgroup, the results were very positive, at least if you are agreeable with the p-value. Now, this is the position over which it was thought that, well, maybe spironolactone may be helpful in HFpEF. And I know that, Steve, you have a different opinion on that.
I do. And when this discussion came up, I recall, I'm not going to probably say this correctly, but Lloyd Fisher, who Milton knows very well, wrote a little definition of intention to treat. And what he basically said is, look, once you randomize the patient, they belong in the group to which they're randomized, regardless of their adherence, regardless of whether they stay in the trial, that you don't get to, decide that some patients that you randomized were good patients and some patients were bad patients. And I felt very strongly about this. It wasn't like there was a single site where there was evidence that the data were made up. I mean, I've seen trials where there was a site that everybody agreed you had to throw that site out because it was fake data. This was something like half of the data came from these countries in Eastern Europe. And if you let me throw out half the data in many trials that are neutral or show no real benefit, I can make the trial look very good. And so I felt very strongly that that was a very bad precedent to set. The investigators designed the trial. They looked at those sites and they met the standards for the trial. I do trials. We do, and we look at sites carefully. We qualify the sites. And once they're qualified, they get to enroll and randomize patients. And we're not allowed to throw them out later because we don't like the results that came from those sites.
But Steve, let me tease you actually. You are against throwing out this patient coming from Russia and Georgia, it's a subgroup, right? But with Paragon, you just said that patient with totally normal ejection fraction, well, there may be a reason that they are not responsive, and I'd rather throw them out and redo the maths, and you end up by a re-engineered trial. Am I wrong in getting your interpretation and double standard here?
No, it's wrong. I mean, look, we had Paradigm and we had Paragon. We had quite a carefully done trial with good quality data. It was part of the problem is that TopCat, like many trials sponsored by the NIH, is done on a shoestring. And, you know, I didn't find that the quality of the data was so compelling. But even more importantly, the argument was being made that these sites were essentially fake sites, that they didn't even give the patient the drug. And there was some evidence presented that the patients didn't take their drug. Well, some of the trials that we do, we suspect that some of the patients weren't taking the drug, but we don't throw those patients out. We don't throw those sites out. And so with TopCat, we didn't have priors. You know, Bob Temple uses the term priors, that, you know, when you make an interpretation of a trial, you do it based upon the prior evidence. I didn't find a lot of prior evidence to suggest that this was not the correct result. So I was not willing to allow half the sites to be thrown out. I'll be very interested to hear what Milton has to say. You're very thoughtful about these kinds of matters, but I felt the ITT principle was so important here that we shouldn't set the standard that if you don't like the results in a couple of countries, that you can throw those countries out and then reinterpret the trial.
So
understanding, let me just comment on that, Milton, and I'll get to my understanding that these the smoke and gun was not only that adherent issue and that the patient in Georgia and Russia were not taking the drug, but it's their event rate was dramatically low. It doesn't really fit with the event rate in HFpEF patients. So there are other reasons, not only adherence, but also that they may haven't had the disease at all.
So let me say, you know, probably of all of the trials that I've been asked to give an opinion about, TopCat probably is the one that gives me the greatest amount of pause. It is the issues here are really complicated, but let us make sure that we are all in agreement as to where the lesion is. The lesion in TopCat was the execution of the trial. That was the lesion. So during the course of the trial, it is really important for the leadership of the trial to monitor the recruitment of sites, the event rates in sites, to make sure that the quality is good. Every trial has to do this. It is part of quality control. And quality control in this trial failed. And it didn't fail at one site, it failed on a very significant scale. And when you have a trial where the execution of the trial was like it was in TopCat, and the execution was a failure in the trial, it failed the trial. And then you say, well, despite this executional failure, we can learn something from this trial. Well, I think we actually can learn something from this trial. What we should learn from this trial is don't execute trials like this. You know, trials deserve better. Patients who sign consent deserve an answer. The academic community deserves an answer. Do I believe in the result in the Americas? I do. But just because I believe in it doesn't mean it is actionable. And that is the key concept. And so I can believe in a result and still believe that decision-making shouldn't rely on it.
I consider TopCat a very good hypothesis generating trial. Basically what it suggests is that if you enroll the right patients in the right way, that this drug may well work. And I would love to see another trial done with spironolactone carefully in patients. They could be in Eastern Europe. They just have to be the right patients.
So let me just emphasize what's amazing is that the academic leadership on this trial was wonderful. It was great. They really wanted to do the right thing. The sponsor just put them in a situation where they just couldn't execute the trial they wanted to execute, and that the operational failure here is at the sponsor level, not the academic leadership level. It's very important to understand that.
Yeah, very good investigators.
Great.
Top quality investigators. If given the resources, they would have been able to avoid this problem. But
and Steve, during the course of the trial, they actually asked all of the relevant questions and were not provided with the data that normally would be provided to academic leadership. As Steve says, if we had certainty here, if we actually knew that with confidence, high confidence, that spironolactone worked, then another trial, placebo-controlled trial with spironolactone in a heart failure and a preserved ejection fraction would be unethical. But there is a trial going on like that. The SPIRIT
trials.
is two trials. They're both SPIRIT, right? If I ask?
Yeah, both SPIRIT. One SPIRIT with double R and one SPIRIT with one single R. The SPIRIT with double R is the registry randomized trial. Yes.
Right. So we always need to give credit to our colleagues who are doing hard work. So there are two SPIRIT trials, spelled a little differently, and they're both testing spironolactone versus placebo. And if we knew that TopCat was definitive, these trials would be unethical. These trials would be unethical. So the fact that two groups thought, well, we really need more data. That speaks volumes.
And that patients have been stratified on the basis of being enrolled on the basis of NT-proBNP or simply history of heart failure hospitalization. Now, this is taking the totality of evidence and everybody. When patients were randomized on the basis of history of heart failure, the trial was negative. When the patients were, the subgroup of patients enrolled on the basis of high NT-proBNP, taken everybody, including the Eastern Europe, the trial was significant. So what is your take on this?
So you learned something very important. You learned in this trial, which is why it's a very nice hypothesis generating trial. You learned about a better way to find the patients in subsequent trials to ensure that you have the population that is likely to benefit. I've made mistakes, many mistakes in trials that I've done. And I feel badly about it, but I learn from it. And I think that's what happens here is we all learn from this.
One valid question, actually, the whole issue, and especially that the two trials have been brought to the committee almost at the same time, was felt by many that this was because we are in an area of unmet need, which is HFpEF, right? So do you expect that this sort of re-examination would follow in other conditions, or the other sponsor would take argument and get back to the FDA and say, hey, look, we look at the data differently, or whether it is really because there is an unmet need?
I'm going to make a statement that's a bit controversial. I usually avoid controversy, as both of you know, but in this case, I'm going to say it. the fact that there's a high unmet need doesn't mean that our standards for interpretation of evidence should be radically altered. This happened with this drug for these children with muscular dystrophy. You know about that, Milton, I suspect.
Yeah.
And what happens is when there's a high unmet need and people are willing to reduce the level of evidence needed, then mistakes get made. One of the problems with the current way the FDA works is it's a lot easier to get a drug on the market for an indication than to get it off the market. And so I don't think we ought to dumb down the level of evidence just because there's a high level of unmet need.
If we take the position that because there is an unmet need, we can use evidence which is substandard, oh my God, then every disease becomes an unmet need.
You said, oh my God, I mean, the highest unmet need right now is COVID. And, and we can see that actually the standards of high quality has not always been followed. And then there is a real issue. And I can't agree more. I mean, the higher the need, the higher the standards, but it's not applied right now with the COVID trials. Is that right?
If we accept substandard evidence, a year later, we know almost nothing more than we did a year ago. And this is in spite of the fact that billions of dollars and tens of thousands of people have been evaluated. The only reliable evidence for most things related to COVID has really just emerged from the vaccine trials. And almost everything else has come in at a level which is less than optimal. Not everything.
So and we have talked about cardiovascular, we have got HPAF and COVID. How about oncology, right? We have spent one full day at CVCT discussing and contrasting cardiovascular and cancer trials.
So many cancer trials are with agents that target a very specific genetically defined subpopulation. That subpopulation is typically not very large, but it is very well defined. And because it is a targeted therapy for a genetically defined entity, when you do that, because you understand the disease state, then the effect sizes tend to be large, 50, 70% reduction in risk. Those are impressive. We never see those in cardiovascular. And the reason we don't see those in cardiovascular is we don't understand the diseases that well. We can't identify subgroups.
Thank you so much, Steve. It was a really wonderful discussion. We have really hardly scratched the surface of many issues, but we did make a point that there are multiple ways we need to interpret data, and there are some skills which are cardiovascular clinical trial skills, and this is how we try hard with these blogs at CVCT Cardiobrief and CVCT meeting in order to educate people to better understand and interpret the results of trials in order to make common sense and take the results in their clinical practice. I would like to stop here and thank you both for this wonderful discussion and invite people who have been watching this actually to interfere and send their comments, and we'd love that this open up a full discussion, like Milton say, a civil discourse discussion, so that we may enrich this and go beyond that today's stream. Thank you so much to both of you.
Thank you. Thank you so much.
Bye, everybody.
Bye.